Thank you, Chairman. Today I would like to present TAVI, where are we in 2022, the surgeon's perspective. First of all, I declare no conflict of interest. I am the one who stays between SAVR and TAVI. I just look for them for fighting. So sit here, grab the popcorn, and see who wins. I try to list the important point that the surgeon should know about TAVI, and I think all of this thing is a important point that the surgeon should know. The TAVI, or the Transcatheter aortic valve implantation, or TAVR, the Transcatheter aortic valve replacement, you can use its both. The first in vivo was performed by Dr. Aaron Kraber, and now it's 20 years later after the first in vivo TAVI was performed. As everyone knows that we choose the patient according to the risk. However, the risk assessment is not just only the SCS score or the Euro score. Actually, the risk assessment includes the risk estimation. It is the SCS score and Euro score, yes. But it also includes the major organ dysfunction. The procedural impediment is mean that some population we cannot perform the standard surgical AVR safely, and also the failures. The risk estimation from the previous study, the low risk defined as less than 4 and the high risk defined as more than 10. But now, some definitions were changed. The low risk in the AHA used less than 3, but however, the ESC still use less than 4, but the high risk both guidelines used more than 8. After the TAVI launched in 2002, everyone knows that there is an invasion of the technology. The first TAVI paper performed in the prohibitive list, and now they move into the low risk. This paper summarized the risk and age in the major trial. You can see that the SCS score reduced from 11.6% and down to 1.9%, and the age reduced from 80 to 70 years old. However, there is some myth about the low-risk TAVI. In the surgeon's perspective, after analyzing this paper, you would expect that the isolated surgical AVR in the low-risk population, the outcome should not worse like this. The atrial fibrillation rate is high at 40%, death and stroke 3.3%, and stroke at 30 days 2.4%. It's quite high. However, if you look in the meta-analysis, and I try to summarize all of these demographic data into the table, you can see from this graph that even there is a low-risk population, but the age is elderly. The patient is 77.43% in average. Even the ejection fraction is good, but the New York class 3 and 4 is 40%. 1 in 5 the patient has the diabetes, nearly 10% have the CVA, 1 in 5 have the CAD, and a lot of comorbidity. So if we look precisely in this low-risk population, is the elderly low-risk patient. So I think the outcome in the isolated surgical AVR in the elderly population like that, the outcome is acceptable. This is a paper from 2018. They predict the future of the management in aortic stenosis. They propose that in every kind of the aortic stenosis, the patient should consider TAVI first, and then in a special circumstance, the surgical AVR has a role. But actually, it's not. Because we concern the durability of the valve. In the TAVI era, the definition in everything about TAVI is well defined in order to perform the better research design, and also about the valve dysfunction. There is a definition in everything: the bioprosthetic valve dysfunction, structural valve, non-structural valve, hemodynamic valve deterioration, or whatever. Look at this table. If your patient has a means transvalvular gradients more than 20 millimeters mercury, or increase of the mean transvalvular gradients more than just 10 millimeters mercury, they will be considered as the moderate hemodynamic valve deterioration. And this paper comes from the UK. They look at the long-term durability of the valve, and mean follow-up 5.8 years, and the length is between 5 to 10 years. The result, the peak gradients at the follow-up is lower than the post-procedure. And in conclusion, they conclude that at 5 to 10 years post-implantation, there is 91% freedom from the SVD, and incidence of the serious structural valve deterioration was less than 1%. In this paper, I try to summarize all the study that has durability studies. You can see that the average years of the follow-up is length around 5 years to 10 years. However, the SVD incidence is less than 5% in every study. And if you look at the Notion trial, we study the low-risk growth, even in the surgical AVRs, also have a higher SVD, 26.1%, but don't forget about the definition. And there is a well-designed simulation study model from TAMP. He stimulated the patient from the partner 3 and between the TAVI and SAVR cohort with the mean age 73%, low surgical risk, and look at the outcome, death on the knee reoperation and follow-up for 40 years. He concluded that the durability of the TAVI must be 70% shorter than surgical AVR. That will impact the life expectancy of the patient. So the conclusion in their study is that the durability concerns do not influence the initial treatment decision in the older, low-risk population. So the major another concern is age. This is guideline from AHA 2020. They start with the risk. If the patient has a high risk of the prohibitively, the TAVI is concerned for sure. But if the patient is low risk or the intermediate risk, the age will be a major concern. If the patient is older than 80 years old, the TAVI is considered. If the patient is younger than 60 years old, the surgical AVI is considered. But if they stay in between, there is room for discussion. And this is a new guideline from ESC 2021. If the patient is younger than 75 years old with the low risk, the surgical AVR is considered. However, if the patient is older than 75 years old or high or prohibitive risk, the TAVI are considered. And if the patient is 75, younger than 75 with intermediate risk, there is room for discussion. This is a Thai TAVI guideline in 2021. We use the risk first and then we define by the age, like the AHA. However, our age group, we use the surgical AVR when the patient is less than 70 years old and TAVI in the patient more than 80 years old. And now, how about the TAVI outcomes? If you read a lot of the paper of the comparative between the SAVR and the TAVI, you will know that the outcome will be like this. The surgical AVR had a higher bleeding, higher atrial fibrillation, stroke, and a prolonged hospitalization. In other hand, the TAVI had a higher vascular complications, conduction disturbance, the permanent pacemaker implantation, and also the perivalvular leakage. But if you look year by year, look at this outcome of the kidney injury, you can see that the TAVI, they can improve the incidence of the kidney injury going down. And however, in the surgical AVR, it looks like it's going up. And the stroke, the TAVI is lower than the surgical AVR, but it's not statistically significant, and the improvement is not significant. But if you look at the length of stay, the surgical AVR is constant at 7 days. It is the best that we can do. However, the TAVI, they can still improve. They can reduce from 6 days to right now 3 days. The reasons of the improvement is come from the minimalist approach. They use a local anesthesias, minimal conscious sedations, fully percutaneous exercise, use a thoracic echo instead of the tiny esophageal echo. And you look at this graph, you can see that at 2018 in US, they performed the local anesthesia for TAVI more than the general anesthesia. And the next concern is about the paravalvular leakage. Everyone knows that more than moderate paravalvular leakage has an impact on the life expectancy of the patient. However, the valve also have evolutions. They know that the paravalvular leakage is one important pitfall of the valve. You can see that from the core valve evolved to the evolute R, and the evolute R evolved to evolute Pro. In the evolute Pro, they have a polycranial skirt outside of the stent frame that can seal the paravalvular leakage, and you can look at their result. 1 year, no severe or the moderate PVL. The next concern is the pacemaker implantation. Everyone knows that the radial force of the TAVI compresses on the conduction system and causes a heart block and end up with the pacemaker implantation, and it must be higher than the surgical AVR for sure. But however, if you look at the most recent year, they can improve it. But how? It's about knowledge of the anatomy. They study about the membranous septum length and study between the depth of the implantation depth compared to the membranous septum length. And from this study, the results reveal that the risk factors include the procedural right button block. If the membranous septum length is less than 5 mm, implantation depth is more than the membranous septum length and the size of the valve. And from this knowledge, they propose about the MIDAS approach. The MIDAS means minimizing depth according to the membranous septum. They use a cusp overlap view, isolate the non-correlated cusp, and aim the non-correlated cusp depth less than the membranous septum length, but not higher than 1 mm depth in order to avoid the pop-up of the valve. And after they use the MIDAS approach, they can reduce the new pacemaker implantation to only 3%. So, what is the surgeon role in TAVI? There is so many TAVI access sites, but however, the percutaneous technique can possible just only for the transfemoral and the transcaval. However, the other alternative approach need the open techniques. The transapical approach is maybe the second option from the old day, but actually it is not quite familiar for even for the surgeon. And now we have the transaxillary approach. If the axillary vessel is acceptable, some institutes even propose about the transcatheter approach that with the 0% of the stroke. And the other familiar and promising technique is a right leg aortic approach, especially for the minimally invasive surgeon. You can approach the ascending aorta via the right anterior thoracotomy very easy. However, the outcome, the alternative approach cannot compare with the transfemoral approach. This maybe come from the patient population that has higher comorbidities. And also the development of the TAVI delivery system that can reduce the size. The transfemoral approach on this day is nearly more than 80 to 90%. Another role of the surgeon in TAVI is the management of the perioperative complication. If there is an access site injury, yes, they can manage with the intervention, but somehow the open surgery may be better. The fatal complication like cardiac perforation or the annular rupture, this is our job for sure. And also the ascending aortic dissection, that no any option available, just only the open surgery. The valve dislodgement, yes, we can pull it down to the descending aorta just in order to do not interrupt the blood flow. But if the valve is flipped or something happened like in this picture, the open surgical removal may be better. And if there's some unstable low cardiac output syndrome, we can help them to put the ECMO in and then stabilize until the operation is finished. The coronary obstruction is also the major complication that can occur. The intervention is the first management in this complication, but if it fails, the CVT is the last option. After talk a lot of things right now, the TAVI is friends also for the surgeons. In my idea, the TAVI is like a Spidey. They can be both. They can be your neighbor, best friend, or the bad Spidey. If you study in the landmark study, if you feel that they perform the TAVI in the younger population and also the lower risk day by day. But if you look in the real world, this study is come from Germany. They studied the characteristic of the patient in the 2013 to 2020. And you can see that the age of the patient is not going down much. It's still the same. And the age distribution is also the same. The thing that changed is just only the ACS score in every age group. And if you look at this graph, after the partner launch and the FDA approved, the annual number of the patient undergone the AVR is increased 103%. And they can reduce the mortality by half. And if you look deep down to the trend and number of the AVR, the surgical AVR is not reduced, even a little bit higher, but the number of the TAVI is increased significantly. From this graph, maybe we can interpret that the TAVI is not come to replace the surgical AVR, but they found their own place here in the area of the elderly. And if you look at the improvement of the mortality, the surgical AVR cannot improve the mortality more than this, but the TAVI can improve. From this graph, we can interpret that the improvement of the mortality in the most recent year is not come from the surgical AVR, but come from the TAVI. And if you look deep down to the mortality after the TAVI, you can see that the improvement of the mortality is not come from the high risk, but it's come from the low risk and the moderate risk population. And the other thing that can make the TAVI to be the good friend for the surgeon is that they can help us not to perform the redo surgical AVR after the surgical AVR fail. But somehow some physicians think outside of the box. I think everyone has seen this picture before. There is some new idea about which is the first valve for the patient with quite younger population, like 40 to 60 years old. Do we perform the surgical AVR first, or we perform the TAVI first and then redo surgical AVR? If you look at this picture, you can see that there is a new scenario that no one knows about the outcome yet. This is the TAVI in the surgical AVR, TAVI in TAVI, and the surgical AVR after the TAVI. For the TAVI valve involved after the surgical AVR, the surgeon should know that which surgical valve is the ideal valve for performing TAVI. The ideal valve should have a radial opaque marker that is quite clearly seen from the fluoroscopy. The next thing is the size should be big, because the high residual gradient is one important factor is the internal diameter of the previous valve. However, there is some mention about the balloon valve fracture to a large size of the valve, but you have to think that not every valve can be fractured. And the last, the special design of the surgical valve may cause a major problem to the TAVI, especially that valve that use the pericardial leaflet mount outside the strut. There is a high risk of the coronary obstruction after performing TAVI. And this is a paper that summarized the outcome of the TAVI valve and compare with the redo surgical AVR. I will summarize in the next table. The outcome look like the same with the native valve, but if you look there, the new pacemaker implantation in the TAVI in the surgical valve is lower, but redo surgical AVR is higher, and severe PPM is higher in the TAVI valve than the redo surgical in AVR. You can see that the two outcomes are completely opposite from the native valve studies. And now we talk in the opposite. If we perform the surgical AVR of the TAVI, what happened? This paper performed about the surgical AVR after performed the TAVI. They report the 19 patients, 8 cases is immediate conversion, 11 cases is early and late conversion. The mean is around 18 months. Even if they can achieve a very good result, but they still report about the potentially high risk population and the unique technical implications. They say that the surgical AVR after the TAVI is not the same with the redo surgical AVR after SAVR. And this paper comes from Osaka of Professor Kulatani. They report the technique how to remove the TAVI valve to perform the redo surgical AVR after TAVI. And this is a new technique that the surgeon should know in the future. Whatever, the TAVI will be the good Spider-Man if they help us in the case that we cannot do the surgical AVR safely. And in the last minute, I will talk about the heart team. It is important that you should not divide that you are the surgeon, you are the interventionist, you are the cardiologist, but you are the one team that try to treat the aortic stenotic patient. I'm quite lucky that I have a chance to participate in the greatest heart team I ever seen in Osaka University with Professor Toru Kulatani. Everyone help each other. We have a good conference. We have a good discussion. The cardiologists, the cardiac surgeons, scrub nurse, and the medical assistant, the anesthesiologist. They are just only one team that help each other. I'm trying to make my team to be like that too. And finally, The heart team is like Avengers. We have just only one purpose. We try to treat the aortic stenosis. So help each other, not to be the enemy. Thank you for your attention.